So our last topic today, but certainly not least, I was impacted by one of the slides earlier that showed really the fact that the standard of care for MDS patients hasn't changed a whole lot in the past few years, and why that's so important, and what we're talking about here as far as the importance of the research that's happening, what we're learning in what could be some maybe promising new treatments for our patients, or even just new thoughts for clinical trials, and really where the future of treatment for MDS patients is headed. So maybe we can do this by saying, what do you think, each of you, is the most promising? And maybe you'll think the same ones, I'm not sure. But
well, we heard a lot about the immune environment, the immune microenvironment that helps it may contribute to the development of the myelodysplastic syndrome or the ongoing progression of the disease to higher risk disease. So targeting the immune system is kind of the holy grail, and using the immune system to, number one, attack the cancer cells, but also maybe dampen down an immune system to prevent it from actually making the disease progress is an area of a lot of active research. So I'm very excited about that. And in particular, this whole concept of inflammation making patients who have lower risk myelodysplastic syndrome progress to higher risk disease or leukemia is sometimes driven by this inflammation that can be targeted. And there's a lot of exciting new drugs in the pipeline for targeting this aberrant inflammation that may halt earlier forms of this disease and even maybe cure it, for example, if it actually does what some of the agents we are being tested, we hope they do. So I'm very excited about those areas of research.
Thank you. Dr. Behar?
I would echo that. I'm really excited by the large number of new things that are being brought to MDS, and I put them in two different categories. Some that I think are more near-term on the horizon are actually being borrowed from other diseases where they've been either approved or shown efficacy. So acute myeloid leukemia, for example, has had a bunch of new drugs that were recently approved in the last few years, and some of them may be very efficacious in MDS, and we're starting to see the clinical trials that are helping prove that. So I think in the near term, we'll be adopting some of those therapies that are applicable in AML in MDS patients, and they'll help out. But some of the new modalities that Rena was talking about, addressing the immunologic landscape of patients, looking at totally novel pathways that haven't been tried before, I think this gives us hope that we may find something that's really transformative in MDS, and there will be more and more clinical trials aimed at doing this, and I hope that we make quick progress there too.
Thank you. Dr. Santini?
And being the third one, I absolutely agree with my colleagues, but I would also like to say that what we are actually trying to do now is to couple new agents, more than one agent, with the standard of therapy. Meaning that we want to attack the myelodysplastic cells, the cells that maintain the disease, from different points and from different angles, so that we can have more specific targeting of some alteration, as we mentioned, and at the same time have an immunological help or a stimulation of the immunity against the dysplasia. So we are changing our approach, coupling more agents at the same time, and taking care that the safety of the therapy is maintained and the patients do not have a risk of excessive toxicity. I think that this is a new approach for MDS. We never did it really. We always had standard of care for high risk plus one new agent with different mechanism of action. And for lower risk, again, we used only single drugs usually. And now we tend to couple more drugs to have a synergistic effect and higher efficacy. So this is something also that is new and promising. I would really hope.
Wonderful. Well, thank you so much for your time. I think this meeting has shown that getting everyone together, the researchers, even some regulatory, patient advocacy groups, and clinicians can really benefit patients. And again, thanks for your time. I know it's been a busy day. Thank you.
Thank you.